Bismillah ar-Rahman ar-Rahim. Antidepressants Part 1. Introduction. The symptoms of depression are feelings of sadness and hopelessness, as well as the inability to experience pleasure in usual activity, changes in sleep patterns and appetite, loss of energy, and suicidal thoughts will occur in the person. Those group of persons or patient will have abnormal behavior to the pleasure reactions. In the most type and normal type, there is a limit in the behavior of the sadness or the enjoy, while those patients who have depression, they will be lower than the normal sadness or hopelessness, lower than the normal sadness or hopelessness. If we suppose that this is a baseline, this is the baseline for the sadness or the reaction to any community action, those will be lower than this reaction. Those will be lower than this reaction. Mania is characterized by the opposite behavior. That means those group of patients who suffer from mania will have the opposite behavior. Those will be upper than the limit, than the normal limit. Here in this part, those will be upper than the normal limit for the behavior. Also, enthusiasm, anger, and rapid thought and speech pattern, extreme self-confidence will have, and impaired judgment. Those are all the person who suffer from mania will do mostly. Now we came for the mechanism of antidepressant drug. Most clinically useful antidepressant drugs potentiate either directly or indirectly the actions of norepinephrine and or serotonin in the brain. This, along with the other evidence, lead to the biogenic amine theory, which proposes that depression is due to deficiency of monoamines such as norepinephrine, serotonin, at certain key site in the brain. So there is a theory which is called the biogenic amine, and the theory said depression is occurred due to the deficiency of monoamines like norepinephrine and serotonin. Most of the drugs that act on the depression will either directly or indirectly will potentiate the action of norepinephrine and or serotonin in the brain. We see here that the synapses, what is occurred, we have mediator of a neurotransmitter that will mediate the nervous signal, and those nervous signal will came from the presynaptic in order to be released by the vacuole into the synaptic cleft, and after that, when it is attached to postsynaptic receptor, it will propagate the action potential to the next neighbor nervous cell. And also this is occur for the norepinephrine, and also for the serotonin by the same mechanism. It will came here in the synaptic cleft and bind to the 5-HT receptor, which is the serotonin receptor, propagate the action potential and the signal to the next cell. So in this picture we see we have noradrenergic neuron and we have serotonergic neuron, and both as due to the biogenic theory, say that when there is less neurotransmitter like serotonin or less neurotransmitter like noradrenaline, there will be less binding for the postsynaptic neuron and depression will occur. Conversely, the theory proposes that mania is caused by an overproduction of these neurotransmitters. So anything that may increase the production of the neurotransmitter like norepinephrine or serotonin will be more available to the postsynaptic receptor. This will lead to mania, according to the biogenic amine theory. However, the biogenic amine theory of the depression and mania is overly simplistic. Why? Because it fails to explain the pharmacological effect of any of the antidepressant and anti-mania drugs on the neuron transmission, which often occur immediately. However, the time course for the therapeutic response occurs over several weeks. This is a problem because sometimes the action will be occur after several weeks. How long this will occur? How this is occur? It failed to explain the pharmacological effect of those drugs and that act on both antidepressant and act as anti-manial drug, because the action of it will occur immediately, while the course will occur and the response will be after several weeks. Summary of antidepressant. We see here that there we have many groups of antidepressant drug, like selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors, atypical antidepressant, this is the most newer one, tricyclic antidepressant, and monoamino oxidase inhibitors. We came for the first group, which is called selective serotonin reuptake inhibitors. The selective serotonin reuptake inhibitors are a group of antidepressant drugs that specifically inhibit the serotonin reuptake. It will be specific for the serotonin reuptake. However, 300 to 3000 fold greater selectivity for the serotonin transporter as compared to the norepinephrine transporter. From its name, selective serotonin reuptake inhibitor, we see here it is highly specific for the serotonin transporter than the norepinephrine transporter. This contrasts with the tricyclic antidepressant and serotonin norepinephrine reuptake inhibitors that non-selectively inhibit the reuptake of both norepinephrine and serotonin. Here, the mechanism of action will occur by highly reuptake of the serotonin. We see here when those molecular neurotransmitters is evacuated from the presynaptic into the synaptic cleft, and some of them will be bind here and others will be reuptake, and the others will be reuptake into the presynaptic neurons again, into the presynaptic neuron again. The reuptaking inhibition will lead to increase the concentration of the serotonin in the synaptic cleft, and this will lead to higher binding of those serotonin to the receptors and give postsynaptic neuron signal more than the usual. Moreover, the selective serotonin reuptake inhibitor have little blocking activity at muscarinic, alpha adrenergic, and histaminic H1 receptor. Therefore, common side effect will be associated with tricyclic antidepressant such as orthostatic hypotension, sedation, dry mouth, and blurred vision are not commonly seen with the selective serotonin reuptake inhibitor because they have little blocking activity for the other receptors. Because they have different adverse effects and are relatively safe, even in overdose, the selective serotonin reuptake inhibitor have largely replaced with the tricyclic antidepressant and monoamino oxidase inhibitor as the drugs of choice in treating depression. The selective serotonin reuptake inhibitor will include fluoxetine, which is the prototypic drug of this group, paroxetine, citalopram, escitalopram, and the pure S enantiomer of citalopram, fluvoxamine, and sertraline. Action: the selective serotonin reuptake inhibitors will block the reuptake of the serotonin, leading to the increased concentration of the neurotransmitter in the synaptic cleft, as we said. This is the presynaptic inhibitor receptor. This is a presynaptic neuron. When the serotonin will came in the synaptic presynaptic neuron and released by the presynaptic neuron, the neurotransmitter will be in a limited concentration. This can be either bind in the postsynaptic, like in this case, binding in the postsynaptic response, or it will be reuptake, in the presynaptic neuron. This is before the treatment. It is called presynaptic inhibitory receptors. While when a drug is given to the patient, more of the neurons will be released in the acute effect of the drug with a modest postsynaptic responses. So there is a higher chance for the binding for the receptors and give the signal to the neighbor cells. And if we give the drug that will lead to inhibit the reuptake of those neurotransmitters, more concentration will occur in the synaptic cleft, and the antidepressant drug will block the reuptake of the neurotransmitter, lead to more chance for binding of the neurotransmitter to the postsynaptic cleft. In cases of a chronic effect of the drug, there is increased strong postsynaptic responses because increase in neurotransmitters synaptic cleft concentration. This will lead to higher chances for the binding of the neurotransmitter serotonin to the postsynaptic responses due to the enhanced postsynaptic receptor activity, leading to a therapeutic responses. This is occur due to the effect of the chronic effect of the selective serotonin reuptake inhibitor by stopping the reuptake of the serotonin, leading to more concentration of the neurotransmitter. I hope that the mechanism of action is cleared. Antidepressant, including selective serotonin reuptake inhibitor, typically will take at least 2 weeks to produce significant improvement in the mood, and maximum benefit may require up to 12 weeks or more. The therapeutic uses: number 1, depression. It is the primary indication for the selective serotonin reuptake inhibitors, for which they are as effective as the tricyclic antidepressant. A number of other psychiatric disorders also responded favorably to the selective serotonin reuptake inhibitor, and this is include obsessive compulsive disorder, panic disorder, generalized anxiety disorder, post-traumatic stress disorder, social anxiety disorder, premenstrual dysphoric disorder, bulimia nervosa. Only the fluoxetine is approved for it. Pharmacokinetics: all of the selective serotonin reuptake inhibitors are well absorbed after oral administration. Food has a little effect on the absorption except for the sertraline, for which food increases its absorption. The majority of selective serotonin reuptake inhibitors have a plasma half-life that range between 16 to 36 hours, and the metabolism by the cytochrome P450 dependent enzyme and glucuronide or sulfate conjugation is occur extensively. Fluoxetine differs from other members of the class by having a much longer half-life, about 50 hours, and the half-life of its active metabolite S-enantiomer norfluoxetine is quite long, averaging 10 days. It is available as a sustained release preparation, allowing for only once week dose. Fluoxetine and paroxetine are potent inhibitors of the cytochrome P450 isozymes CYP2D6, responsible for the elimination of tricyclic antidepressant, antipsychotic drugs, and some antiarrhythmic and beta-adrenergic antagonist drugs. Adverse effect: headache, sweating, and anxiety and agitation, gastrointestinal effect like nausea, vomiting, and diarrhea, weakness and fatigue, sexual dysfunction, changes in weight, and sleep disturbances. Additionally, selective serotonin reuptake inhibitors have been associated with hyponatremia, especially in elderly patients and patients who are volume depleted or taking a diuretic. Overdose with selective serotonin reuptake inhibitor does not usually cause cardiac arrhythmia, with the exception of citalopram, which may cause QT prolongation. You have to note that the tricyclic antidepressants have a significant risk for arrhythmia in overdose. Seizures are possibility because all antidepressants may lower the seizure threshold. All selective serotonin uptake inhibitors have the potential to cause serotonin syndrome, especially when it is used in the presence of MAO inhibitor or other highly serotonergic drug. Serotonin syndrome may include the symptoms of hyperthermia, muscle rigidity, sweating, myoclonus, which is clonic muscle twitching, and changes in mental status and vital signs. Discontinuation syndrome. All of the selective serotonin reuptake inhibitors have the potential to cause a discontinuation syndrome after their abrupt withdrawal, particularly the agent that shorter half-life and inactive metabolite. Possible signs and symptoms of selective serotonin reuptake inhibitor discontinuation syndrome include headache, malaise, and flu-like symptoms, agitation, irritability, nervousness, and changes in sleep pattern. Student, you have to differentiate between the discontinuation syndrome and the serotonergic syndrome. Now we came for another group of antidepressant drug, which is the serotonin norepinephrine reuptake inhibitors. Example, we have venlafaxine and duloxetine inhibit the reuptake of both serotonin and norepinephrine. It inhibit both of them will inhibit the serotonin and norepinephrine. This agent, which is termed serotonin norepinephrine reuptake inhibitors, may be effective in treating depression in patients in whom selective serotonin reuptake inhibitors are ineffective. If those group is ineffective selective serotonin reuptake inhibitor, so we will go to the this group, which is the serotonin norepinephrine reuptake inhibitors. The same scheme, we see here that this drug or this group of drug will act on both the noradrenergic neuron and on the serotonergic neuron by inhibiting the reuptake of the norepinephrine, reuptake of the norepinephrine, making more concentration of the norepinephrine for the postsynaptic receptors, and it will also at the same time it will inhibit the serotonin norepinephrine reuptake inhibitors drug, the reuptake of the serotonin, making more neurotransmitter of the serotonin binding to the postsynaptic receptors. So it will act on both the noradrenergic neuron and the serotonergic neuron reuptake inhibition. Vilafloxacin is a potent inhibitor of serotonin reuptake, and at medium to higher doses is an inhibitor of the norepinephrine reuptake. Duloxetine will inhibit the serotonin and norepinephrine reuptake at all doses. Both drugs may increase blood pressure and heart rate. Another group, which is atypical antidepressants. The atypical antidepressants are a mixed group of agents that have action at several different sites. The group include bupropion, mirtazapine, nafazodone, trazodone, vilazodone, and vortioxetine. Bupropion. It is a weak dopamine and norepinephrine reuptake inhibitor. It is used to alleviate the symptoms of depression. Bupropion is also used for decreasing craving and attenuating the withdrawal symptoms of nicotine in patients who are trying to quit smoking. It has a relatively low risk of drug-drug interaction. The use of the bupropion should be avoided in patients at risk for seizures or those who have eating disorders such as bulimia. Mirtazapine. Mirtazapine enhances the serotonin and the norepinephrine neurotransmission by serving as an antagonist at the presynaptic alpha-2 receptor. Additionally, some of the antidepressant activity may be related to the antagonism at the 5-HT2 receptor, which is the serotonin receptor. It is sedating. Mirtazapine is sedating, which is considered as an advantage in depression patients who have difficulty to sleep because of its potent antihistaminic activity, but it does not cause the antimuscarinic side effect of tricyclic antidepressant or interfere with the sexual function like the selective serotonin reuptake inhibitors. It increases the appetite and weight gain. Here we see where the mirtazapine will occur. It will act on the noradrenergic neuron at the alpha-2 receptors. Nifazodone and trazodone. These drugs are weakly inhibitors of serotonin reuptake. Their therapeutic benefit will appear to be related to their ability to block the postsynaptic 5-HT2A receptors. Both agents are sedating. Trazodone is commonly used off-label for the management of insomnia, and trazodone has been associated with priapism, and nifazodone has been associated with the risk of hepatotoxicity. Both agents have mild to moderate alpha-1 receptor antagonism, contributing to the orthostasis and dizziness. If you have a question, you can write it in the Google Classroom to discuss it. Thank you very much.